And similarly, if you look at outcome measures, such as in diabetes, such as control of glucose, control of cholesterol and blood pressure, those also improved in the year before and after the new contract was introduced. So again, showing that perhaps this contract did have an impact on quality of care. And again, this is only possible because of the high use of primary care, electronic primary records in the UK. So that's overall, but also we want to know how people vary by their type of patient group as well. So we looked at things like whether improvements were similar for different age groups, and again, this slide shows that all age groups did show an improvement in the control of their diabetes in these 2 years. But in fact, younger patients had worse control overall in both years, which actually is very important because it means they're storing up problems for the future. So it highlighted the fact we need to really focus on those younger people to make sure they improve their diabetes management. And I think later on the speakers will speak about how that can be done using things like eHealth and NHS Direct. And similarly, we looked at ethnic differences. And again, you can see all ethnic groups did benefit from the new contract. But again, there are some stark differences with, in particular, South Asians and African groups having worse control of diabetes than some other groups. So those are sort of short-term changes. Again, working with Brent, which is in North West London, we also work with them on using data from their GP records to look at longer-term changes in the management of long-term illnesses. And again, this is another example from diabetes. And here we looked at differences amongst white, Asian and black ethnic groups in the recording of 3 key risk factors for diabetes, which were blood pressure, glucose control and cholesterol. And as you can see, there are quite stark improvements over the 10-year period in control of risk factors, but there's still room for improvement. So even by the end of the period, about 0.7 of patients actually had these 3 risk factors measured. So still scope to improve that further. And if you look at outcome control as opposed to just simply measurement, which is clearly more difficult to achieve, we find even starker changes. So at the start of the period, only a small proportion of patients had all 3 risk factors controlled. It's blood pressure, cholesterol, and glucose. And by the end, it had gone up, but to no more than 20%. So again, scope to improve that. But again, using data like this, we can actually pick up these differences and target patients and practices to actually improve quality of care. So finally, I'll talk about the most recent development, which is a scheme developed by one of my colleagues, Dr. Josip Carr from Hamilton Fulham PCT, jointly with Imperial College, which is a scheme called QoF Plus. So QoF Plus was designed to implement a step change in the quality of long-term illness management and reduce health inequalities, and also drive up quality without impacting too much on other areas of activity. So it's a very large investment by the PCT. It's about £2.5 million a year, and it involves a partnership between the PCT and Imperial College, and it involves a multimodal approach to quality assurance, which includes a number of different initiatives. So there's strong clinical leadership, there's training and support for GPs, there's funding and financial incentives to incentivise quality improvements, and there's motivation using analysis tools. So using a data warehousing tools, we can take out data from each practice, compute scores for each, quality scores for each practice, and that data can be fed back to them to actually allow them to improve their quality of care. And that's linked with patient-level management tools for calling and recalling patients and trying to identify patients who are missing out on high-quality care. And it's being evaluated by us currently to see what impact it has. So I'm just showing here some of the early changes from that scheme. So the first change is looking at blood pressure control in people with diabetes, with hypertension, with high blood pressure. So as you can see, the red line is the PCT, and before this scheme came into play, the PCT is running just below average for London and England for blood pressure control in hypertension. This line here is the top 10% of practices in England. Following the scheme being brought into play about a year or so ago, we saw a very stark increase in control of blood pressure in people with hypertension. So that was due to the targeted training, the feedback to patients and practices, and the use of data from electronic primary care records. So again, it's showing you can actually lead to some very dramatic improvement in quality of care with the proper use of information technology and targeted feedback of data to practices and patients. And similar results in other areas. So this is diabetes and blood pressure control. So again, if we look at this, we see the PCT is doing probably around average for England. And again, following this scheme coming into play, we saw quite a stark increase in blood pressure control in diabetes. Not as much as you might hope. We're still below the top 10%, but we're hoping to reach there before too long. And the final slide shows the use of beta blockers in people with heart disease. And again, if you look at this this performance indicator in primary care, the PCT was doing below average until recently, but when the scheme came in, we jumped up to well above average, and again, we're heading towards now the top 10% of practice in the country. So, you know, again, it just illustrates how you can actually improve quality of care with the use of electronic records in primary care and targeted feedback and support to practices. The final thing I'll talk about briefly is cardiovascular screening. So we're all aware in London there are many patients with heart disease and diabetes and high blood pressure who are not really being picked up at the moment. So again, using data from electronic records, we're able to actually introduce screening and risk stratification for these conditions and intervene to actually improve people's care and hopefully in the long term lead to improved outcomes. But that's the hardest part of this process. And this just showed some of the changes that we've actually managed to achieve in the first year or so of this scheme. So if you look at things like people with blood pressure measured, people with cholesterol measured, people with glucose measured and so on, and history of heart disease recorded and so on, and patients with history of diabetes recorded, these have all shot up within a 1 year period. So again, illustrating the fact that we can actually use data to actually drive quality improvements. So this is part of what's called the Health Checks program, which is a national scheme to improve the detection of people with heart disease and diabetes. But locally, we've modified it to actually use electronic records and are trying to make it a much bigger program to really drive up quality, identify unmet need, hidden disease, and really drive up quality of care. And the final thing was looking at smoking. Smoking and this is advice on lifestyle and diets, or prescribed statin for cholesterol. So again, showing very dramatic increases. So the use of statins in people with high risk of heart disease shot up from 18% to 55% within a year, and and advice about diet and lifestyle shot up as well in these high-risk patients. So again, showing quite dramatic improvements in quality of care, which hope in the long term will also lead to improved outcomes and hopefully decreased use of acute hospital care as well. So those are some of the benefits. There are clearly some challenges, and one is that we do have multiple systems in use in primary care. So currently in the UK, we have 3 main systems in use for primary care records. There's a EMIS, Vision, and System 1. We're still not very good at linking data with hospitals, so in many parts of the country, the data doesn't really link very well with hospital data, in particular data from outpatients or acute admissions. And there's still quite a long way to go on things like dealing with variations in disease recording and the accuracy of data recording by GPs. The other issue is around the volume of data. So once your data on 1 million patients or 10 million patients with thousands of items per patient, those data sets become very, very large and complex and difficult to analyse. So we work closely with our Department of Computing, for example, to try to handle those issues using large-scale, high-performance computing and powerful software algorithms to actually code, clean, and use these data sets for research. And there are also clearly ethical and legal issues as well about using these kind of data, which we'll discuss later on during this day. And clearly the UK is only a part of this picture. So across the world, we're seeing very large investments in e-health programs, both in Europe, the US, and even now in developing countries who are also investing in this area. And that's going to facilitate research, audits, and quality improvements. And also it will allow cross-national comparisons. So currently for our research, we tend to be very UK focused on health policy issues, but I think in the future we'll see a lot more cross-national research than we've done in the past because of the development of these electronic patient records across the world. So clearly, so this is a fairly rapid run through, and I hope I've shown to you why data from these primary care records is important. It provides information on the entire population, and as we advance our IT systems in the future and e-health systems, we'll see more data being made available for use by a range of stakeholders, including patients themselves and the public, NHS staff, researchers and industry. But clearly there's a lot of work to be done for the future, and so there is need for collaboration between industry, academics, patients, the public and the NHS on this area. So I'll stop there, and if you want more information, there are 2 publications which discuss these issues in more detail. Thanks very much.